numbers are optimistic. Now, obviously, the big issue with prostate cancer is that the morbidity of treatment it's a lot higher than some of these other conditions that we have on this slide. PSA is still the best screening test in 2025, and we know that from some trials. For example, here we have the Göteborg trial, where they did regular PSA testing every 2 years in men 50 to 70 years old, which led to a 29% reduction in prostate cancer mortality. And we also see this mortality decrease benefits from other trials, such as the ERSPC and the PLCO trials. Okay, so here we see that even a single PSA test could be used to reduce prostate cancer mortality. Of course, this number is not as strong. It's only 8% for single PSA screening, but it's still strong signal evidence that PSA screening does work. And this is another trial called the UK CAP trial, where they saw that reduction in prostate cancer mortality after 15 years of single PSA testing. The central challenge we face in clinical practice is striking the right balance. That is, identifying and treating those who will truly benefit from early detection of prostate cancer, while getting our hands off or never diagnosing men that are unlikely to benefit from screening. In terms of screening intervals or guidelines, we recommend, according to our guidelines, we recommend screening every 2 to 4 years. That was the interval that was used in the ERSPC trial, which is the European randomized study of screening for prostate cancer. But that's also something that can be adapted and adjusted based on risk factors and patient preferences. Here is the Kaplan-Meier curve for the before mentioned ERSPC trial, which shows a survival advantage that PSA screening offers. And it's also important to notice that as the years go by, we see the numbers become more favorable. As curves kind of spread more. We know prostate cancer is a slow-growing disease, so that makes sense that the number needed to screen and the number needed to diagnose prostate cancer become more and more favorable over time. According to our guidelines, clinicians can also personalize the risk screening intervals and adapt them to patient risk factors. For example, if someone is between the age of 45 and 70 and the PSA is less than 1, the interval can be prolonged. And we have many studies that show that if a patient is 50 and the PSA is less than 1, no further screening is needed, because the long-term risk of something bad happening is so low that you can stop screening if you want to. At the same time, if someone is 75 and has PSA of less than 3, that is also considered a low risk group. We need to be fair when discussing the risks and benefits of screening with patients, and based on the current literature, we do not do a great job at it. Although clinical guidelines widely recommend shared decision making, it's reported use before PSA testing varies widely, from 11 to 98%, with the higher rates seen in physician self-reports compared to patient accounts or direct observation. If you ask older people who are screened, their urologist or PCP tends to oversell the upside and minimize the downside of prostate cancer screening. It seems that we can do a better job at explaining that kind of things to patients. Clinician may personalize the risk screening interval or decide to discontinue screening based on patient preference, age, PSA, prostate cancer risk, life expectancy, and general health following shared decision making. We still screen a lot of older men that are unlikely to benefit from screening. This is data from men screened within the last during the last 2 years. We see that in the higher age groups, it should be relatively rare or less, way less frequent than in younger individuals, and that's something we also need to take into consideration. If the patient is perfectly healthy, of course we can go for it, but some of these men probably do not need to be screened. And this is just a way of showing whether they're healthy or unhealthy based on estimated mortality rates. And the take-home message of this slide is that there are a lot of guys that are older and are unlikely to live more than 5 or 10 years and are unlikely to benefit for screening. However, they're still being screened. That's also something we should probably reflect more on it. This is data from the Social Security in 2022. If you think of the average life expectancy of a U.S. man, if they made it to 65, and they made it to 65, and they are and they have an average health, they're likely to make it to 82 years. If they're healthier than the average person, their life expectancy might be longer. Life expectancy, we see that on average, that's now dropped below 10 years until for averagely healthy individuals until they're 77. So according to this data, it sounds pretty reasonable to loosely screen men in their upper 70s and 80 if they're healthier than the average guy. But I also think that for some individuals that might be 70 or even younger, they are unlikely to make it more than 10 years and therefore unlikely to benefit from screening. This is a really important guideline statement. The easiest, the cheapest thing to minimize unnecessary diagnosis is to always repeat an elevated PSA. This is data from JAMA over 20 years ago. The take-home summary of this slide is that without doing anything, just repeating the PSA, 40 to 55% of the time, it's going to drop back down to a normal level, whatever you use as a threshold. This is another way of looking at this. This is the Stockholm 3 study where they did PSA, where they evaluated PSA levels in over 1,600 men, and they repeated the PSA values were between 3 and 10, and then they repeated it 8 weeks later. The grade distribution is the change in PSA over 2 months, and what they're trying to find are the people on the red line here. And that's grade 2 or grade 2 disease or higher. And the bottom line of this slide is that if the PSA after 8 weeks the PSA has gone up and you repeat it, and if it's at a similar level, it is probably significant cancer. So it's probably a real value. And that's a probability value. If you repeat it and it goes even higher, that it's less likely to be prostate cancer. And on the other hand, if you repeat it and it stays relatively the same, it's a more indicative of likely grade 2 or higher prostate cancer. Baseline PSA is an exceptionally strong predictor when measured early before other health age-related conditions such as BPH or prostatitis begin to be co-founder. It offers a high degree of clinical clarity and risk stratification value. This data was published JCO in 2016. They went over 21,000 men. Almost all of them had a normal PSA, but even within normal PSA values in their 40s and 50s, even if they have normal PSA values, these numbers were predictive of possible prostate cancer decades down the road. So the authors of this manuscript suggested that we could technically use, and it'll be a good strategy to use median PSA for men in their 40s and 50s, kind of like the baseline, and re-stratify them based on that number. Not everyone, of course, should be screened every year or two, and there are people that we can encourage to get screened every 4 to 5 years, depending on the PSA's value and other risk factors, of course. We should offer earlier screening for people at higher risk of developing the disease and from bad things happening to them. Here are some of these risk factors that increase the risk of prostate cancer. We have germline mutations. We have individuals of African ancestry. There are also risk scores or polygenic risk score that can give you an estimate of the likelihood of a man developing prostate cancer. Of course, we have family history that is not only for prostate cancer, but also for breast, ovarian, or pancreatic cancer, which typically warrants germline testing. And even if they don't have a germline abnormality, if they have family history, of course, we can be more aggressive with screening. The PSA velocity, it's a metric that could be misleading in some instances, and it does not seem to matter as much once we know everything about the patient, that is patient history and PSA value. In this figure, we have a representation of PSA values in an ascending order in the x-axis, and the percent of prostate cancer patients with these PSA values, with these PSA density values in the y-axis. And that is for figure A, and for figure B, we again have PSA velocity in the x-axis and prostatitis in the y-axis. And when we compare these figures A and B, we see that higher PSA velocities are more associated with prostatitis than with prostate cancer. So biopsy in this patient is more likely to show inflammation the higher the PSA velocity is instead of prostate cancer. Here's another study by Beakers and
Quick question.
Oh, yes, sir.
Back to the last point that you said, for the PSA velocity, that's pretty interesting. Do you know whether there's any like sensitivity or specificity data on that?
Uh, in terms of sensitivity and specificity, I'm not sure of the numbers, but I think based on my reading, also kind of interpreting this article, it also seems to be that once we let's see.
That's fine. I'm just wondering whether you stumbled upon something while you're doing your research, but yeah, no worries.
Okay, yeah, it seems like that's an interesting question, Mo. I can look into it and get back to you later. But
Sure.
yeah, apparently they're more likely to be associated with either inflammatory conditions or something that we don't understand instead of
Wonderful.
prostate cancer, and of course that is for the higher PSA values.
Of course. Thank you.
You're welcome. Here's another study by Beakers and colleagues on the role of PSA velocity as a predictor of prostate cancer. And the take home message is that once we know someone's age, total PSA, family history, digital rectal exam, you can no longer predict the likelihood of grade 2 prostate cancer or higher any better if they have their PSA velocity. So do not biopsy someone if just based on PSA velocity. And I think that has to do also based on how related associated PSA and PSA velocity are. So it doesn't add any value to know it once we know all those other factors. Now we'll briefly discuss the role of free PSA. Free PSA is the fraction of unbound enzymatically inactive PSA circulating freely in the bloodstream, and is considered to be a stronger predictor of having clinically significant cancer than the total PSA itself. It is also thought to be key in refining who truly needs for their workup. Here we see that lower free PSA is associated with higher probability of clinically significant cancer, and with higher free PSA values being indicative for more benign pathology. Here's one example of the power of free PSA and how we could use it as a tool to determine whether to biopsy a patient or not. Here we're using the Prostate Cancer Prevention Trial Risk Calculator, which is an online free tool that provides an assessment of prostate cancer risk based on age, PSA, race, prior biopsy, and family history. Here we have a 70-year-old African-American patient with a PSA of 4, no family history of prostate cancer, digital rectal exam was normal. This patient has never had a biopsy. When we plug in the free PSA value, we see that this patient has a 15% chance of high-grade prostate cancer. If we play with the free PSA values, we see that that number can substantially change. For example, if the same patient had a free PSA of 8 instead of 20, the chance of prostate cancer goes up to 52. That it's threefold increase. So that's something to take into consideration. If we were to compare a free PSA of 8 versus 50, that would be even higher, 7 or 8-fold increase. So very interesting. This also brings us to guideline statement number 10, which talks about integrating validated risk calculators such as the PCPT that we previously went over to inform the shared decision-making process regarding prostate biopsy. We can plug these values and play and tell the patient, hey, you have X% chance that this might be grade group 2 or higher. And that's something we can use to help the patient in the shared decision-making process. Here is some data from the PLCO trial. We have 6,700 men with baseline free PSA, and they have also routine PSA during a 20-year follow-up. The blue line represents men with a free PSA higher than 25. The red line represents those with a PSA less than 10, and the green with PSA values in between. You can see how, based on your free PSA, we can estimate, seems to be a strong predictor of the likelihood of being diagnosed with clinically significant cancer. This next slide is about PSA density, something that it's used relatively regularly in clinical practice, and it's externally powerful as well. Let's have a look at this figure. The gray distribution again is the distribution of PSA density. The red line is grade 2 or higher, and we can see how PSA density is directly proportional to the likelihood of finding potentially meaningful cancer. In terms of DRE, the guidelines say that.
Uh,
Yes,
would
yes,
you
sir.
be able to go back to the previous slide, Reynier, please? Thank
Sure.
you. So this kind of data is what has influenced our practice. So we believe that PSA density is the best PSA derivative that we can use. And the reason is you can see the red line. There is almost a linear correlation. As the density goes up, the probability of diagnosing clinically significant cancer goes up. The other interesting thing is the benign diseases go down and the grade 1 prostate cancer remains stable. So we are just looking at the density helps us to focus, not overdiagnose grade 1. It's important. We are decreasing the diagnosis of benign disease, increasing the diagnosis of clinically significant disease. That's why density is important. When we looked at the other question that Mo asked with regard to sensitivity and specificity, when we looked at the PSA velocity in the previous slide, you see there's no correlation. If you look at those histograms, they were up and down, whereas with prostatitis, it went up. And higher the velocity, the incidence of prostate clinicalism was actually lower in those bar diagrams. And that's why velocity is a poor marker, whereas PSA density can be used across. And it's also fairly accurate because we get accurate measurements either from cross-sectional imaging or from ultrasound. It's reasonably accurate. And then we can calculate a PSA density on most patients. The free to total PSA has been validated in the range of 4 to 10, not in patients with lower values. So that's something we just need to be aware of when to use the free to total PSA ratio.
Oh, thank you for that comment, Dr. Balaji. I agree with you that now that you mentioned that it's interesting that free PSA is a very powerful test, and it's only been approved for those with a PSA between 4 and 10. But interestingly, we have a substantial amount of patients with a PSA less than 4 that also died of prostate cancer, and some clinical trials have evaluated free PSA in individuals with free PSA less than 4, and it's also proven to be effective uh, re-stratifying disease. So that's something that we'll probably see moving forward in the future, that that threshold might change.
Thank you.
May I add one thing, just Dr. Balaji's comments about the PSA density, just to remind everybody that almost all of our local MRI reports attempt to make at least, and it's often succeed to putting us a PSA density. So it's usually something when we do an MRI that we will see it there, and of course the MRI result is now almost trumps the PSA value in terms of steering the course of the patient. But it's an interesting thing. If we have the volume, we can get the PSA density. Thanks.
Thank you, Dr. Marino. Also, an important point. We know that it's my understanding that the PSA density is not done routinely unless you order. It's not part of the regular PSA screening. And we'll talk a little bit later about DRE and its clinical relevance in terms of screening. And one of the important points of the DRE and its value, it's that it could be help to estimate. If we don't have the PSA density value, we could use the DRE to help us come up with an estimate of that number based on our measures of the prostate and the PSA value.
Thank you.
You're welcome. In terms of DRE, the guidelines say that clinicians might use the DRE based on their preference, but the literature actually says that it has a very low value as a diagnostic test for screening. For example, here's a systematic review, a meta-analysis that show that as a screening test is not a very sensitive test, while the DRE has a positive predictive value similar to PSA, meaning that when it is abnormal, it carries a comparable likelihood of indicating cancer. its CDR of cancer detection rate is significantly lower, meaning that it detects fewer cases overall. In the PROBASE trial, the detection rate for prostate cancer via DRE was also very low. However, of course, like I just mentioned, DRE is still recommended as part of the workup for elevated PSA. And obviously, if you're thinking about proceeding with biopsy, you should also perform the DRE. Dr. Marino, how do you feel about that? About the utility of the DRE in recent years, and how often do you perform it in your practice?
Well, we used to be taught when I was in residency that, and when I was that a palpable tumor is most likely already extracapsular, and that was the feeling at that time. But now I'm doing less and less finger-guided biopsies. If I have a patient that has a nodule, I'm almost doing a lot of it by the MRI and the guidance and the MRI fusion guidance. So I think the degree of induration, when you don't have that information, maybe that you can maybe tell you where to put the needle for sure. Then you select that spot. But as far as screening, I think if you do a screening and you find that, but I just find that I use it less and less, and I find that the other providers are doing less and less finger examinations. I more often do biopsies on patients that tell me they never had a finger examination. I would defer to Dr. Balaji in terms of that.
All right. Thank you, Dr. Marino.
Yeah, so we kind of moved away from routine DRE now because of this data. There are a couple of other reasons. One is physical examination is intrusive. And although traditionally medicine has relied on physical exam, there is a clear role for it. But if we can gain the same information by other ways, then we don't have to intrude the patient with the physical exam, and rectal examination is probably very, very intrusive. So, and I think that's one thing. And in clinical practice, clinic floor and all that, rectal exams takes more time. The area where it may be useful is if we do suspect locally advanced or prostate cancer, or somebody presents with a very high PSA and you want to quickly examine, and you have a hard rock prostate and you want to sample it. Those are areas that it may be valuable. But in the way we practice medicine today, there's less role for DRE. And that's why you guys don't see us routinely performing DRE even in a urology office, unless there's a definite indication for it.
Thank you, Dr. Raj. That makes sense. If we look at the cancer detection rate, if it's just like this study found 0.05%, that's not a very optimistic number, and we should not use it as a single measure to screen our patients.
The other challenge we've had with DRE, which is fortunately less common now, is what we call false positive DRE, because this is very, very subjective, and one can feel a firmness, hardness, and a variety of descriptions, and that might prompt a biopsy despite having a normal PSA. And of course, this is historic, given that we have MRI now. But before those days, a lot of these DREs prompted prostate biopsies, which may not result in diagnosing clinically significant prostate cancer. So that's another risk, and that's why we have moved away from routine DRE. Thank you. Thanks.
Got it. Thank you, sir. Okay, now we're going to talk a little bit about biomarkers. These are recommended when the PSA is elevated as a reflex test to reduce the number of biopsies while maintaining the detection of significant disease and also reducing overdiagnosis. A biomarker is any molecule, whether in blood, urine, or tissue, that is a sign of a disease or abnormal process such as cancer. And today we will be focusing on those biomarkers that are relevant in early detection of prostate cancer. We've already talked about PSA and some of its isoforms, and now we want to focus on some of the other biomarkers. First one we'll talk about today is the Prostate Health Index, or PHI, which is a blood test that assesses 3 different isoforms of PSA. It is FDA approved, and FDA approved for patients with a PSA value between 4 and 10. And in this study by Dr. Stacy Loeb and colleagues, patients who had a PHI score of 25 or less were less likely to have cancer. They were also less likely to have aggressive disease, and the performance of the PHI score, or the combination of the 3 different components, outperform any of the individual PSA isoforms. So we previously talked about the importance of free PSA, but now we see that with the PHI score combining free PSA, PSA, and pro PSA, it seems to be even a more powerful indicator of significant disease than the before mentioned free PSA. The 4K score test.
One other thing, Reynier, I know we're going to talk about variety of biomarkers in this space. This is one of the cheapest one. The PHI costs less than $40. It's a calculation using a PSA derivative. So if we are going to order a test to enhance, in addition to PSA density, this might be a preferred one because of the cost, and it can be easily implemented in our laboratories. Okay.
Thank you, sir. Definitely something
Can I just ask a question?
Sure.
Back in the early 2000s, I think 2003-ish, complex PSA was kind of getting some traction as being more specific for significant disease than free and total. Do you have any thoughts on this in your review, Reynier or Dr. Balaji?
Complex PSA, I'm not familiar with that term, complex PSA. What does that stand for?
It's a protein bound. So, there's free PSA, which is unbound PSA and felt to be due to benign disease. Complex PSA would be bound likely to alpha-1 chymotrypsin, right? That's the active enzyme that PSA is involved with. So bound PSA is potentially a surrogate, for that total ratio. And there was a time years ago that was felt to be a better test than the free and total. And so you're not mentioning it now, which makes me feel like it's kind of fallen out of favor. And I certainly am not an expert in this, and I'm truly asking the question without having an opinion myself.
Right. Probably Dr. Bala, you can jump in and help here with this question. But based on my review, we've kind of moved away from the bound or complex PSA, and we now believe that unbound or free PSA it's a stronger predictor of significant disease. Dr. Balaji, what are your thoughts on that? I mean, if without reading about it, I would think that if we moved away from that, from the bound PSA or complex PSA towards free PSA, it could probably be due to being associated with other inflammatory or benign disease compared to cancer. Dr. Balaji, what are your thoughts on that?
Yeah. So, Joe, I recall talking about complex PSA as well. And more recently, I'm just thinking it's just the reverse of free PSA, Joe. And because the free PSA performs well, I think there's been less pursuit of role of complex PSA. I remember hearing that too early years, and more recent years we just focus. I think it's just a reverse of free. So unless there are a variety of other complex PSA, and
it sounds,
yeah.
Yeah, it sounds as though it should be. It's just looking at a fraction
Yes.
one way or the other. And so, okay, good. I can put that to rest in my brain. Thank you.
Yeah. The other thing, Joe, is going to talk about 4K test. The 4K test is a proprietary formula using variety of sub PSAs. And I'm just wondering whether they are dividing the complex PSA and there's a certain complex PSA that's more of a driver of a negative biopsy. Yeah, I don't know, but I agree with you. I recall, but we don't talk about it much. I'm not sure why. Okay, thank you.
Okay, the 4K score test combines a total of 4 different kallikrein proteins. These are total PSA, free PSA, intact PSA, and human kallikrein 2. With patient, we combine this with patient age, DRE results, and the result for prior prostate biopsy to provide a probability score from 0 to 100 of detecting clinically significant prostate cancer. We see that the higher probability score were associated with clinically significant or high-grade prostate cancer. And again, a full model combining the full kallikreins with those clinical parameters did better than any model that leaves out any of the individual components. They are also they also report in this study that what seems to be a challenge with most of the biomarkers, which is that the performance of a test depends on the threshold or cutoff we use to decide to act. For example, if we choose a threshold of 12 to proceed with a prostate biopsy, you would avoid 51% of biopsies. You only miss 3.2% of higher grade prostate cancer. Now we'll discuss some of the urine-based tests. The first one we'll talk about is the My Prostate Score (MPS). This is the first version of this test that combines PSA-3 and T2-ERG with serum PSA. And this test was updated. I believe it was updated last year, actually. Now we call it MPS2 to include 18 targets in total instead of 3. That's 15 new ones added to the original 3. And the focus is to improve the detection of grade group 2 prostate cancer or higher. This test has a negative predictive value of 99%. And with the threshold of 10, you can avoid 35 to 46% of unnecessary prostate biopsies. The Exos DS analyzes exosomes collected from first catch urine, and it's designed to detect grade group 2 prostate cancer or higher. At a threshold of more than 15.6, you can avoid 20% of negative biopsies. And at that particular threshold, you miss 2% you miss grade 2 or higher 2% of the time, and you would miss no grade group 3 prostate cancer or higher. The third urine-based biomarker is select MDS. This is a combination of DX1 and HOXC6 in addition to other clinical variables. And the goal also is to improve detection of grade group 2 or higher. And the interesting thing I found about this test is that it has an area under the curve of 0.9. And then the last urine-based test biomarker is the MIR or MIR Sentinel test. These are three different versions of the test. One version detects any prostate cancer, the second one clinically significant prostate cancer, and the third one is designed to detect high-grade prostate cancer. This test also had a surprising area under the core 0.9A with a specificity and sensitivity of 0.9. Oh, and point to mention is that some of these biomarkers have not been validated in diverse populations or greater scale. So these numbers, we also need to be careful when analyzing this number, but these kind of preliminary results are optimistic. We also know about the confirmed NDX. This is the last test I'll talk about. And this is a tissue-based test that assesses the methylation status of 3 different genes, which are listed here. And the concept behind this test is the fact that when you have a cancer area that are surrounded by normal or benign tissue, even that normal benign tissue surrounding the cancer might harbor molecular changes that could inform you of the if there is cancer that you couldn't miss on the biopsy. I think this is a really interesting test. I was thinking about highly suspicious prostate cancer. You do the biopsy, you don't find anything. There's something that we could do to see, hey, we probably didn't hit the target. Let's have a look at this test to see if that's the case. The confirmed NDX test was validated by the MACLO study in 2013. About 500 patients who underwent initial and repeat biopsy conducted within 30 months with an initial biopsy showing no cancer, and then the repeat biopsy showing cancer. They performed the confirmed NDX in all of the patients, and they found all of the biopsies that show grade group 2 or higher on the repeat biopsy had methylation changes. This test also reported a negative predictive value of 90% and resulted in a decreased repeat biopsy rate of 64%. And when we put all the different biomarkers into a table, we look at the performance profile. We see that they seem to be very similar in both initial and repeat biopsy. And in general, when we look at the data that is out there, we can see that these biomarker, the overall decrease, when we combine them, it's between decreasing unnecessary biopsies is about 20 to 30%. And they minimize the detection of grade group 1 prostate cancer, while only miss less than 5% of grade group 2 or higher. We currently have limited studies to perform a head-to-head comparison of these biomarkers, but I think it'll be something interesting to see in the future. Last but not least, the UA guidelines say that we should not order that we should use all of these tests to improve risk stratification before proceeding with a prostate biopsy. All of these tests are considered optional. We can use them in specific scenarios. One example that I can think of, if let's say we have a patient with a negative positive MRI, we have a benign biopsy, but the PSA density is high, or the free PSA is high, and you still suspect clinically significant disease, then you could use the biomarker to risk stratify the preferred option during the shared decision-making process. It's also a lot of influence of patient preference, of course. If we have patients that want to get tested, that's also something we should take into consideration. Here are my closing points. PSA is still a cornerstone of prostate cancer screening, and this reflects PSA isoform. The different biomarkers can help us identify clinically significant disease and avoid overdiagnosis. Guideline-based screening strategies, including risk calculators and shared decision-making, enhance personalized care, and awareness of all the mentioned PSA pitfalls and adequate interpretation are critical to prevent harm for an over-testing or over-treatment. Here are my references. Thank you so much for your attention. I'm happy to take any questions the audience might have.
Reynier, thank you very much for presenting this, all this data, and for stepping up and doing this work. I know it's a lot of work. I don't know if you're able to jump slides, but do you remember that bell curve that you showed of the repeat PSA in 4 weeks or 8 weeks, where a patient that has an isolated elevated PSA? I think that's the one. Yeah. No, that's not the one. That's the PSA density.
I think
a little bit further back. That one. Is that the one?
Yes.
Repeating PSA. Okay. You mentioned that if the PSA stays the same, that could be a harbinger or a forewarning of significant disease if it's still persistently elevated. But I'm not sure I heard you correctly on what about if it goes up higher? What is the indication? What does that tell you?
Right. If it goes higher, that could be less indicative of prostate cancer. We think of inflammatory condition, prostatitis, or any other inflammatory conditions.
I see.
So, Roberto,
go ahead.
so if I can make a comment, if we just focus on the red line here, Roberto, this is a beautiful way to represent it. So what this histogram is, the mid is 0, okay, which is where the repeat PSA is the same. To the left means it has decreased by 20 or 40%. On the right means it's increased by 20 or 40%. You see, if it remains the same, that seems to be the peak of clinically significant prostate cancer. Okay, that's point 2. Now, if it goes down, which is on the left, the incidence is lower. And if it goes if it goes up, which is on the right, it's also lower. Which just tells us if the PSA keeps going up within 4 to 6 weeks, that's more too likely to be inflammatory, right? Because prostate cancer very rarely does that. Unless it's very aggressive and it keeps jumping. It doesn't double that much. That's what it's telling us here. So the red line is very telling. This is in contrast to a similar figure that Reynier showed us for PSA density, where you see this red line is almost linear, keeps going up as a density. That's the difference here.
So it seems like a velocity in the short term can be more an indicator of other diseases because prostate cancer doesn't really suddenly jump up.
Yes, and especially the localized prostate, clinically significant, we are talking about metastatic disease. Say if this patient had a PSA of 1,000 and we repeated it 4 6 weeks later, it will be 1,200. And that's clearly progression of metastatic disease. But in this case, where it's localized disease, a few weeks should not be bumping up the PSA like that.
Yes. Okay. Thank you very much. I appreciate that.
Yeah. And guys, I just wanted to, and first of all, Reynier, thank you for presenting that. This is an incredible talk. I think what was striking to me is the way you have grasped this literature and the way you are able to interpret the figures. I think that really tells that you really have a great grasp of reviewing the literature and critically analyzing it. And thank you for doing this, Reynier. I just wanted to editorialize the state of prostate cancer screening using a PSA. We have been diagnosing more, and well, in the past, we diagnosed a lot of insignificant prostate cancer. You ended up treating these men with very little oncological benefit, but certainly has adverse effects on their quality of life. So few things have changed. The first thing we've noticed is the baseline PSA is very informative. So if at any point we get a PSA and the PSA is less than 1, especially in men over 60 years of age and so on, it's unlikely that they're going to develop clinically significant prostate cancer. So we can ease the burden of screening. The second thing we have done is to decrease the frequency of screening. Traditionally, screening has been done on an annual basis. Now we are recommending 2 to 4 years if the baseline PSA is low or within normal limits. By doing that, we have reduced the harm of frequent. I think these are the two major changes. the PSA density has become established as a critical marker, which is reliably obtainable, and it doesn't add any additional cost to what we're already doing. So the challenge with all this biomarker testing and all that is the cost is high, and because we have to screen 200 plus patients to save one life, we can imagine how much cost it will add to the whole screening process, and that's one of the limitations. And FIGHT test is one that doesn't add a whole lot of cost, and the free to total PSA is readily available. So if you really want to use the biomarkers, these are the things that we could use. And if you use a lot of other modern biomarkers, which are a lot more expensive, they're comparators for serum PSA, which we know has limitations and really need to be compared to free to total PSA of 5, which are less expensive. So I think this is a great tool, but if we use them judiciously. And the other thing we have moved now is earlier screening in high-risk population. If we suspect genetic mutations, especially BRCA2 mutation is associated with aggressive prostate cancer, African American ancestry, or a strong family history. So in those patients, we screen them early. If the PSA is less than 1, we can really decrease the frequency of screening. And Reynier talked about in men over 75 years of age, if it's less than 3, don't even bother repeating the testing. And we use a lot of these guidelines in our practice and often advise patients not to get repeat PSA testing because this test can potentially cause harm and we need to be very mindful of it. Thanks, Reynier. Any other questions or comments for Reynier? Again, great job, Reynier. Thank you for doing this. And if there are none else, everybody have a great week. Thanks, everybody.
Thanks, everybody, for your attention, for your comments. Everybody have a great day.
Okay.
Thank you,
Great job,
Reynier.
Reynier. Thank you.
And Reynier, if you wouldn't mind, forward these slides to Melanie and she can forward to the rest of the group. So
Absolutely.
that this is a keepsake slide deck. And thank you for doing this.
You're welcome.
Thank you. Okay.